As a man gets older and his prostate grows, invariably he might have some urinary symptoms, and those include frequency, urgency, difficulty emptying the bladder, the flow gets slower, there's hesitancy, meaning the urine doesn't come out as soon as you would like it to. It takes a little while before it comes out. And also nocturia, which means you get up at night to urinate. So basically, these are all symptoms of an enlarged prostate. And in the beginning, it's really not a big deal. I mean, getting up an extra time at night or going to the bathroom an extra time and maybe taking an extra minute at the bathroom. But eventually, they start really sort of increasing. And unfortunately, they start really having an impact on your lifestyle or your quality of life. In fact, there's a symptom score that was created. It's called the IPSS, International Prostate Symptom Score, and it basically lists all of these symptoms and tells you, well, how much are you having it, 1 to 5. And the most important question is the bothersome score. So if you were to live with these symptoms until the end of your life, how bothered would you be by it? And the reason why this question, this last question is there is because these symptoms in the beginning, they're really not as dangerous for your health. And later on, if they progress, and certainly if they last, eventually they become very dangerous because eventually it increases your chances of getting not being able to urinate at all. But there are really 3 categories of potential treatments. The first one is medical, so meaning you take a medication, and typically it could be an alpha blocker, which is a medication that blocks the alpha receptors in the body, which are present, for example, in your prostate. And the prostate is made up of 2 things: of smooth muscle and of gland tissue. The gland tissue excretes the fluid of a very specific content, and the smooth muscle also is. So basically, if you take an alpha blocker, you block those receptors in the prostate. It relaxes the prostate, and although it is bigger, because it gets relaxed, you can urinate a little bit better. So that's one type of treatment, alpha blocker. That's one end of the spectrum. The other end of the spectrum is surgery, and probably one of the most invasive surgeries and bigger surgeries is it's sort of kept for people that have huge prostates, and it's basically you get an incision in the middle of your lower abdomen, and we find the prostate and remove the prostate and rehook up the bladder to your urethra, or core out the prostate and close the defect, and that's called a suprapubic prostatectomy, which distinguishes it from a retropubic prostatectomy, which is a cancer surgery. So there is such a thing as removing someone's prostate entirely, not for cancer, but rather for obstructive symptoms, because the prostate is so large. Now, in most people, that's not necessary. A step back from that, in terms of the minimally invasive stuff, is the traditional TURP. Basically, what it is putting a scope in the urethra and then from the inside scraping the prostate to remove as much prostate as you can from the inside out in order to open the channel for the urine to come through. Now, there had been developed another procedure that's doing it with a laser. Now, a laser, there's probably like thousands of types of lasers depending on the wavelength and depending on the depth of penetrations and whatnot. And the laser that's used for the vaporization of the prostate is a wide, narrow, in terms of it's a superficial but wide laser. It's called a green laser. So green light laser, it vaporizes the prostate as it touches it, and the benefit of that is that it vaporizes the prostate. The benefit is that as it is vaporizing the prostate, it's also coagulating. So the blood loss is minimal. There's almost no blood loss, and patients, because there's no blood loss and it heals rather quickly, you can go home the same day with a catheter. There is a middle of the road, not surgery, but a procedure which is minimally invasive, and it's called Eurolift. What Eurolift is putting clips, it's like staples, that basically, imagine the prostate is like this, and each staple that you put opens the prostate. So the prostate is like this, and you open it up. Let's say you're looking at me, and now you're looking through the urethra, you're looking through the urethra, and all of a sudden you're going to see the urethra closed shut. That's because the prostate is impinging. Each lobe of the prostate is impinging on the middle of the urethra. So now you don't see my face anymore, and then I put a clip like here, it opens it up. I put another clip like here, it opens it up. So now you can see the inside of the bladder. So you go through the urethra, you're going through the urethra, and then all of a sudden it closes because the prostate is pushing on the middle of the urethra on either side. So this procedure, which is basically putting clips and opening the urethra with the clips, that does not require any cutting, there's no bleeding, there is no ejaculatory dysfunction or sexual changes. With the other ones, with the TURP or the green light, yes, because if you remove the prostate, guess what? You're not going to be ejaculating anymore, because now the bladder neck is gone, because the prostate comes up to the bladder neck. If I remove the prostate, you're not going to be ejaculating. First of all, there's no more prostate, so there's no ejaculation forcibly. With the Eurolift, you continue to ejaculate. So why doesn't everybody get Eurolift? It seems so great. Well, not everybody's a candidate. If your prostate is too large, if you let it go too much, and if the distance between the urethra and the outside of the capsule of the prostate is too large, now we can't do it. It's not going to be effective. So the Eurolift is, if someone has middle of the road symptoms that are bothersome, they can get that procedure, and it could be very effective. Has it been around for 100 years? No, it's a new-ish procedure. There is great 5-year data, but there isn't like 20-year data. Now the TURP, there is great long-term data because we've been doing that surgery since the 80s. But in the green light, there's great long-term data that's been around for 15, 20 years. But the Eurolift it's only been about 10 years, and there's good 5-year data. But it's a reversible procedure. There's no ejaculatory dysfunction. It's done in the office. You don't have to have big surgery. You don't have to have any bleeding. It's reversible. If it doesn't work, or if it works but only for a certain number of years, then you can always. It doesn't preclude you from having a regular TURP or a green light later on. So it doesn't preclude subsequent procedures if it was to fail immediately or in the intermediate term. So that's the benefit and risk for each one.